The pandemic has been especially hard on children and youth. And during the pandemic, our county behavioral health safety net, which helps to manage crisis services for a large swath of children and youth, reported that the numbers of children and youth in acute mental health crisis shot up 2 and sometimes 3-fold. We have had children as young as 8 years old who have been hospitalized due to suicidal ideation. And our behavioral health directors report that, consistent with historic trends with youth crisis, that when students transition back to school in person, this actually results in higher rates of children and youth experiencing mental health crisis. So there's sort of a two-pronged issue here. Having students away from school and social and emotional supports in school exacerbated mental health crises, but when children come back to school, we actually see higher rates of crisis. The issue of children and youth mental health and substance use disorder needs is not an easy or straightforward one. When it comes to behavioral health, children and youth are not simply little adults. Clinically, emotionally, and in terms of treatment, they are different and they require different resources and approaches. Identifying emotional disturbance is a complex issue, and children rely often, and I consider teenagers in this category, often rely on the adults in their life to help them seek care. And we can see some alarming disparities that must be addressed if we are going to achieve equity and eliminate disparities in access to culturally congruent care. When adjusted for population, the county behavioral health system disproportionately serves Black and Native American children and youth, and underserves Latinx and API communities within the Medi-Cal population. Conversely, our Medi-Cal managed care plans serve a disproportionate number of white children and youth in Medi-Cal. Stigma is, of course, a challenge within BIPOC communities, and that is something that can be overcome both within healthcare systems by ensuring access to more culturally congruent services. That means workforce who reflects the community served, who have the linguistic but also cultural capabilities. And in addition, County Behavioral Health has heard from our communities that they do not always want to access the medical model types of treatment. And so we are very lucky in California to have funding sources that go beyond the medical model, such as the Mental Health Services Act, to provide some of those culturally defined practices to reach into those communities.